Welcome to Your Case is on Hold, a JBJS podcast hosted by Antonia and Andrew Schoenfeld.
Here, we discuss the science in each issue of JBJS with an additional dose of entertainment and pop culture.
Take us with you in the gym, on the commute, or most certainly, whenever your case is on hold.
Welcome to episode 92 of Your Case is on Hold. We have quite a listing for you here today with lots of good information and topics to talk about. So we will start by saying that my name is Antonia and I am executive editor at JBJS, and we have here.
I'm Andrew Schoenfeld, associate editor for Methods.
We're thankful that you're all here with us today. Just as a reminder, these opinions are our own and don't reflect anyone else in the JBJS board or anyone at JBJS at all. This is brought to you by JBJS Clinical Classrooms. If you have some learning that you want to do, we've got some great information for you, so please go there. It's also the season of OITEs, so we have options for the OIT prep bundle as well too, and the OITE prep module and the bundle. So great learning opportunities here, especially for residents. We're taking the OITE, really, really good things to study with. Without further ado, we'll start with our top of the pile. Top of the pile, Moving Forward with Gratitude by Bandari. He is our editor-in-chief, and it's permanently free to read this. What's New in Shoulder and Elbow Surgery? Rao, which is also permanently free. Home Call and Sleep in Orthopedic Surgeons, a prospective longitudinal study of the effect of home call on sleep in orthopedic attending surgeons and residents by Lawson. It's free for 30 days, and there's a visual summary. Resident Unions in Orthopedic Surgeries by Lundy et al. Why am I conflicted about enrolling my patients in a randomized controlled trial? An ethical analysis by Krupa. We also have Principles of Level Selection for Instrumentation in Adult Thoracolumbar Spinal Deformity Surgery. Guidelines for Surgery by Sidar. Multi-rod Constructs in Spine Surgery by Benson. And finally, Topical versus Systemic Tranexamic Acid to reduce blood loss after total knee and total hip arthroplasty, a systematic review and meta-analysis. We covered this in our last episode talking about tranexamic acid. Now you can see an aggregate of a bunch of different studies in the total joint world. Without further ado, we're going to go to our headlines. Dr. Schoenfeld is going to start us with Pediatric Spine Frailty Index predicts morbidity and mortality following spinal deformity surgery by Chan et al., and it is permanently free.
Can I just say before I start that, one, I hate OIT. I hated OIT season. Like basically from Labor Day until whatever that was, like the first Saturday in November. Like I just felt like I needed to, like anytime I wasn't like working clinically or in the OR, I needed to be like studying for the OITE. It was such it like ruined the month of October for me all the time. And then
you probably crushed the OIT, right?
I did well on it, yeah. But nonetheless, and I also hated home call because I felt like you don't actually sleep all that well. You're constantly or at least I would. I'm like, oh, did I miss a page? Like, did I sleep through a page? Like,
no breaks. And
then it's like, you come in the next day, you're tired, you're worn out. And they're like, oh, you did it. You were home, like full work day. Like, I know that like the generation before us, they just lived in the hospital or whatever. Like they, walked to school barefoot both ways and all
Backwards.
That stuff. All right. So Pediatric Spine Frailty Index. This study, someone who knows that we do these, who's a friend, actually called me up and was like, I can't, like, we're going to be back to publishing NSQIP studies in JBJS now. So, I cautioned them that this is not like an invitation to submit all your NSQIP work to JBJS. I'm sure that's not what the intent was behind publishing this. And no, I don't think that the average NSQIP study is going to have a high likelihood of success going forward in the journal. But nonetheless, this was a study that was conducted with pediatric NSQIP data. And essentially, they were looking to create a prediction score for morbidity and mortality following spine deformity surgery. And the outcome of interest was a composite. Any adverse events Clavin-Dindo grade 4 adverse events, mortality and extended length of stay within 30 days after surgery. And the adverse events included superficial surgical site infection, deep infection, organ space infection, wound disruption, dehiscence, pneumonia, unplanned reintubation, progressive renal insufficiency, acute renal failure, UTI, coma for greater than 24 hours, stroke, seizure, cardiac arrest, cardiopulmonary resuscitation, VTED, postoperative C. diff, sepsis, septic shock, and catheter-related CLABSI, essentially. So, some of these are quite serious. Others are UTI, and there's a broad variation in terms of, impact and long-term outcomes associated with these adverse events. Their approach was they initially did what they're calling univariable, they really mean bivariate comparisons, looking for significant associations. And then any that they found that were significant, they included a multivariable regression model, which then they performed backward selection using the likelihood ratio to exclude variables without significance in the multivariable context. And then each comorbidity was assigned a score of 1 in an unweighted index, and the other was a weighted index assigned on the basis of the regression coefficient, which they term as beta. So ultimately, they found 6 comorbidities as being significantly associated with the odds of adverse events: severe respiratory disease, GI disease, cognitive/developmental delay, seizure disorder, neuromuscular disease, and asthma. So they did these unweighted, where it's just a count. They did it weighted, where the respiratory disease, seizure, and asthma were assigned 1, GI was 2, and then cognitive delay and neuromuscular disease was 3. And ultimately, the weighted index did not perform that well, so they went with the unweighted index. And that ultimately, ends up being what they are characterizing as the frailty index. But to be very exacting here, words have meaning, and frailty means something. And when you talk about frail patients or patients who have frailty, generally we're talking about elderly individuals, primarily with a diminished physiologic reserve. That's sort of the underlying, underarching concept around frailty. They have diminished physiologic reserve that does not allow them to effectively bounce back from insults to their physiology, such
like
as
surgery.
a fall or a surgery,
right.
or a fall and a surgery.
Yeah, both.
This is where frailty comes into play. Frailty usually takes there's lab values associated with it, serum albumin, there's skin turgor, there's subcutaneous fat, there's, yes, cognitive impairment can definitely play into those things, dementia as an avatar manifestation of frailty, patients with spinal metastases, patients with chronic infections, low BMI because they're losing so much weight because of their illness. When I say frailty and you have a mental image of a frail person, someone with asthma is not that, right? A child with asthma is definitely not that.
Yeah.
How about a child with a GI disease, which again is a very, these are very broad strokes that are prone to ecological fallacy because it's collected the way NISQIP collects and describes them. So a seizure disorder, like that could be controlled. It may not be controlled. Either way, I've seen lots of kids hearkening back to a pediatric rotation, be it as a resident or as a medical student. Nonetheless, I saw many kids with seizure disorders and diagnoses. I would not characterize them as being frail. Even, how about if they had the seizure disorder and asthma? No, still not frail. Also, you have severe respiratory disease here, and asthma. Like, if you have severe asthma, is that not a severe respiratory disease? Asking for a friend.
I just say, depends on your definition.
So I don't, what is what is severe respiratory disease in a pediatric patient that's not at least, in the ballpark of, I think the most severe, most common pediatric respiratory disease is going to be asthma, to my mind. Again, I'm very far removed from my pediatrics rotation. Like the kids haven't been around long enough to smoke enough to have COPD or something, right? Like
that may be more
I
severe.
know, of course, there are other types of, they could have cystic fibrosis. Like I get
That's
that.
more frail. That's different. Right. Very different from asthma.
Right. But that is one type of severe respiratory disease. And if cystic fibrosis should be in this description here,
Very
then
different.
it should say cystic fibrosis.
Agreed. Completely agree.
I think this is a misnomer. It's not the pediatric spine frailty index. It's the pediatric spine severe comorbidity index.
Yeah.
And
yeah, because it is comorbidity. It's all about
that's what it is. That's what it is.
It is.
Cognitive comorbidities, GI comorbidities.
By definition, it is correct.
It's not frailty. It's not frailty in the sense that we use frailty.
Yep, agreed.
So this is a misnomer as far as I'm concerned. Keep in mind, NSQIP is not purposely sampled, nor is it nationally representative. Their outcomes are only limited to 30 days. They recognize all this, of course, but I think this is going to underpredict complications. I think that the composite measure is somewhat intuitive, and also, okay, this. How are you going to change? Like, classifications and scoring systems are useful when they can be used to inform care, change care, are easily understood, and are clinically relevant. So you see someone who has a seizure disorder and asthma and maybe cognitive developmental delay, and you say, okay, well, they're at a higher risk for complications after the surgery.
Okay.
Yeah. I mean, what are you good? Like,
yes.
you're not, for them, we'll use the antibiotic prophylaxis. Whereas for the other one, you're not going to, you know what I mean? Like, I don't think it's going to change anything.
Right. I hear you. And that's the hard part about this. It's not going to move the needle enough.
Or at all. And you're going to get confusion where people are going to be like, oh, I want to use the frailty index for patients who are frail. And then if they try to look at these characteristics, they'll be like, well, none of these things are actually measuring frailty. Like, you can get serum albumin on kids. You can get, I'm sure, there are definitely kids who have
true frailty.
Right.
Able to do certain activities or not being able to do certain activities, but that's not what this is assessing.
Morquio syndrome.
Right. All the glycogen storage disorders we had to memorize.
Right. Yeah. The glycogen storage diseases, they all have like eponyms with like people's, fragile nail syndrome, fragile hair syndrome.
True.
Ellis Van Creveld.
Ooh, like you're bringing up some medical stuff that I have not thought about.
Ellis Van Creveld was like the pet syndrome, the favorite syndrome of the doctor who was the chair at the Children's Hospital where I did my residency. He just was like Ellis Van Creveld. He was always talking about it.
We did lupus. We were pretty boring in comparison.
Yeah, no, you gotta be more esoteric than that.
True, very true. They didn't test that on your OITE though, that's for sure.
Yeah, I don't think this is going to show up on the OITE.
Yeah, that's gonna be one of the hardest.
I think you're safe. You're safe from the pediatric spine. Mark's safe from pediatric spine frailty index.
No Kaiser Sose in this one for sure. So awesome. Well, thank you for presenting that one. We're going to change the narrative a little bit and we're going to switch to another topic. We're talking about maintaining and increasing physical activity is essential for managing cardiovascular and cerebrovascular risks after total knee arthroplasty. It's a nationwide cohort study by Park et al. There's a commentary on this. So what are the cardiovascular and cerebrovascular risks after total knee arthroplasty, and does physical activity play a role in this? Although the exact timing of increased physical activity after total knee arthroplasty remains uncertain, there are studies that show that it does increase between 3 to 12 months. I tell my patients it takes 12 full months to get back to full activity. That said, I do recognize that patients want to get back to activity sooner. You're walking right off the bat. You're moving right away. So you have no excuse to not start walking. We did a study where you put your, Apple Watch or your phone and you counted the number of steps, that to get back to pre-surgical step count, we need at least 4 to 6 weeks. But activity is typically lower after total knee replacement than of non-total knee arthroplasty patients, and we have no idea how cardiovascular and cerebrovascular diseases contribute to that, especially into the short and long-term mortality after total knee replacements. So this is a study looking at total knee arthroplasty patients and the impact of perioperative physical activity on these risks based on a nationwide cohort in Korea. They used the National Health Insurance Service of the Republic of Korea, which covers 97% of the population. So that's nice as opposed to you can't do quite that in the United States. All individuals undergo a national health examination every 2 years beginning at the age of 40. This is mandatory for everyone. Patients who underwent a pair of health examinations at 2 or 4 year intervals and did not have a diagnosis of cardiovascular or cerebrovascular disease at the first examination were included between 2007 and 2017. The TKA group obviously comprised of individuals who underwent TKA, but it was unilateral TKA, and this happened between the first and second health evaluations. And the control group, the non-TKA patients, comprised of patients who didn't undergo TKA patients, and they were initially matched by 1-to-3 ratio by age and sex. They had to complete a minimum 5-year follow-up period after the second examination. After exclusions, which were missing data on activity, less than 1 year between total knee and second health examination, other surgical procedures in the lower extremity within 5 years, they did a 1-to-1 propensity score matching between the TKA and non-TKA groups. Now, this is for my methodology guru here. A 1-to-1 nearest neighbor matching without replacement was performed using a caliper width of 0.25 of the standard deviation of the logit transformed propensity score. And the matched variables were demographic variables such as age and sex, comorbidities, specifically the Charleston Comorbidity Index, medication use such as antiplatelets, anticoagulants, and statins, and lifestyle behaviors at the year of the first health examination, such as cigarette smoking, alcohol consumption, and physical activity levels. So that's why this was nice. They could do all this study looking at it because at each one of these 2-year checkups, they're looking at their physical activity level. My PCP doesn't ask me about my physical activity level at all. So
what happens if you don't show up for your thing? They take you good
off with your head.
Yeah.
I'm just kidding.
They're like, oh, then you're not a problem for the health system anymore because
you're done.
Yeah.
No idea. Yeah. I have to ask someone who's Korean and ask this. It's kind of interesting. So they labeled physical activity as the basis of frequency based on moderate to high intensity activities. So what does that mean? So in terms of frequency, you had inactive or active 1 times per week, or so 1 to 2 times per week, 3 to 4 times per week, or 5 or greater times per week. What were moderate intensity activities? Those included brisk walking, doubles tennis, cycling at a moderate speed, carrying light objects upstairs, and household cleaning. High intensity activities were running, aerobics, cycling at high speeds, heavy construction work, and carrying heavy items upstairs. And they did a Cox proportional hazard models to evaluate the association between physical activity change and disease incident over a 5-year follow-up, remember, after the second visit. So compared with controls who didn't undergo total knee arthroplasty patients exhibited higher incidences of cardiovascular diseases, 19% versus 17%, and cerebrovascular diseases, 26% versus 24%. These incidences were associated with perioperative physical activity levels, meaning higher physical activity levels after total knee arthroplasty were associated with lower risk of both disease. Specifically, if you did physical activity greater than or equal to 5 times per week, it was linked to lower cardiovascular risk and cerebrovascular risk. If you were previously inactive, the greatest reduction in cardiovascular disease risk was observed among those who began exercising greater than or equal to 5 times per week. So you went from not exercising pre-total knee and you started exercising 5+ days after total knee arthroplasty. Those are some dedicated patients. And that does help you. It does reduce both of them. It reduces your cerebrovascular disease. Cerebrovascular disease has the greatest reduction in cardiovascular disease. The greatest reduction in cerebrovascular disease were found in those who became active 3 to 4 times per week. So even if you became active at least 3 times per week after total knee arthroplasty, you can reduce your cerebrovascular complications. If you go 5+, you can reduce your cardiovascular complications. However, if you used to be physically active before a total knee and stopped being active after a total knee replacement, then your risk of cerebrovascular disease increased. If you went from greater or equal to 5 times per week exercise to no exercise, that was the greatest risk. So don't stop moving after a total knee. In fact, learn from those who were inactive beforehand and became more active. That is the most interesting part of things. So initiating physical activity may be a core component of optimizing long-term outcomes after total knee replacement. Now, it doesn't take into account anything like patient satisfaction, walking ability, those type of things that, we say 20% of patients are potentially dissatisfied after knee replacement. Can they exercise 5+ times a week? And what does this exercise look like? They did say some exercises that are there, but where does weight training fall? Where do some of these things, taking a walk, what's a rigorous pace, what's not a rigorous pace? What about light exercise, things like that? So it's nice to have these health data points, but more detail would have been nice to better understand this.
Yeah, as far as the propensity score match goes, it's a very permissive caliper at 0.25. Ideally, we'd like to see it more at around 0.1. Also, I don't really understand how a causal inference test fits in this context. I get that I think they're trying to make the case like these are patients that are very similar to the total knee patients, but that would only really be the case if you could say like these are patients who would be indicated for total knee and then who didn't have it. And I don't think a data set like that is really able to do that effectively.
Completely agree with you there. We're going to look at total knee replacement again in your case on whole featurette at 15-year mortality following periprosthetic joint infection and total knee arthroplasty, a registry study of 8,642 revisions for infection by Christensen et al. It's free for 30 days. So mortality after PJI is truly a concern. It's been compared to the mortality rate in the top 5 cancers in total joint arthroplasty by Benzentowski et al. And it is up there. So it's not a benign condition. People are like, well, I get infected, I get washed out, I'll move on with life. No, it can actually result in mortality. This study looked at mortality over a longer period of time, 15-year mortality. It used the data from the Australia Orthopedic Association National Joint Replacement Registry, included all primary total knee procedures performed for osteoarthritis between September 1st, 1999 and December 31st, 2022. ASA scores were collected starting in 2012 and BMI was recorded starting 2015. The authors used Kaplan-Meier estimate of survivorship and standardized mortality ratios based on Australian period life tables to describe mortality rates following revision for PJI. They also looked at aseptic revisions, but they excluded ones for fracture and unrevised primary total knee arthroplasty. Additionally, hazard ratios were calculated with multivariable proportional hazard models to assess the impact of the risk factors of age, gender, comorbidities, and minor versus major revisions. Because this is a registry study, there were over 831,000 patients in the study with greater than 644,000 patients with no revision procedures recorded, of which 21% of them died in the study period. There were over 35,000 revisions that were recorded, and 1,200 of them approximately were for fracture, which were excluded. There were 8,642 first revisions for PJI, which is the number that's in the title, of which 26.2% of them died. And then the aseptic first revision group, about 18% of them died. So what happened at 5 years after surgery? If you had a revision for PJI, 16.1% died. At 10 years, 34.4%, and at 15 years, over half the patients died. So 53.4% of patients who had a revision for PJI died. When you adjusted for age, gender, and calendar year of the procedure, the standard mortality ratio for revision was 1.33. How does that compare to aseptic revision? That standardized mortality ratio was 0.84, and for unrevised primary total knee arthroplasty was 0.79. So the take-home message here is that patients with revision for periprosthetic joint infection had a 33% greater than expected mortality compared to aseptic revisions and primary total knee patients. So what were associated with increased risk of mortality? Probably not surprisingly, increased age and higher ASA. What does that mean? So with patients who are greater than or equal to 75 years of age compared to those who are less than 55 years of age, there was a hazard ratio of 9.3. They also found an increased standardized mortality ratio for younger primary total knee arthroplasty patients compared to older primary total knee arthroplasty patients, and younger revision patients compared with older revision patients, especially those with revision for infection. Patients who underwent revision for infection also had ASA scores of 3 to 5 and had higher mortality compared to ASA scores of 1 to 2. Male patients had a higher overall risk of mortality. However, females with revision for infection had a higher standardized mortality ratio compared with males with the revision for infection. Underweight status and obesity greater than class 2 had increased mortality. Patients who had a BMI of 25 to 35, though, had the lowest mortality rates compared to the general population. So try to get your BMIs optimized even before infection surgery, although that's very hard to do, obviously. Patients who were categorized as obese class 3 had the greatest mortality rates compared with their matched populations. Minor revisions for PJI were associated with increased mortality within the first 5 years, but there were really no differences between minor and major revisions for infection after 1.5 years. So be careful with PJI. PJs are bad. There was high mortality in the early postoperative period, and the excess mortality did persist up to the 15-year mark in the study. Not surprisingly, mortality was unsurprisingly worse for patients who were older and higher ASA scores or had worse comorbidities. Patients who were male, underweight, or obese also had increased mortality. So these population studies are interesting. I wish there was more granular data on this to really understand mortality and reasons for it. And, mortality itself is not necessarily due to the PJI per se, but it was, an indicator probably of their poorer health if they were to become infected.
So I just have a couple of points that I wanted to make on this mortality risk study. Essentially, the question for me is really, one, why the patients are having the risk of infection. And I think it is telling in that regard that the ASA, they only had that since 2012. So they don't have it for the earlier sets of patients. And while they did account for the year of surgery, I do think there are still secular trends that are not effectively controlled for between how these surgeries were done and the potential infection risk in 1999 versus, say, 2022. And then also when they're talking about 15-year risk, that's not for patients who had surgery in 2022. That's really for patients who had surgery from 27 and earlier. So you're not really getting a good assessment of the baseline comorbidity risk. Are the patients passing away just because of the infection, or is it a chicken and egg kind of phenomenon where the infection is a manifestation of their, not to belabor or bring up frailty again, but really frailty or baseline risk of adverse events? And it's through that mechanism that is why they're just, and I do think that there is some potential for that. And that's why you're seeing the difference between like the younger patients and the older patients that they were showing, because a younger patient who develops an infection may have a different sort of biophysiologic profile from an older patient who develops their infection or doesn't develop an infection. The younger patient should be more resistant to developing an infection, such that when they do develop an infection, it's really showing that this person is in a totally different landscape and may be at greater risk for mortality as a result. There's also a higher risk of mortality, right, for the aseptic revisions as compared to the unrevised primary total knee arthroplasties. And how that comes about is probably...
I agree with you.
Yeah. Just, there's a certain burden to having another surgery or multiple additional surgeries.
I agree. Not benign. All right, going to our honorable mentions, starting off with the outcomes of extra-articular subtalar arthrodesis for valgus deformity of the hindfoot in patients with cerebral palsy, a radiographic and pedobarographic study by Park et al. With an infographic. Extra-articular subtalar arthrodesis has generally been recommended for treating severe valgus deformities of the hindfoot in patients with cerebral palsy. However, it's unknown whether restricted subtalar joint motion affects the shape of the foot during continued growth in children. The purpose of the present study was to evaluate the effectiveness and longevity of extra-articular subtalar arthrodesis in ambulatory patients with spastic CP, with a specific focus on its impact on the final foot shape and plantar pressure distribution. Extra-articular subtalar arthrodesis was associated with a high risk of progressive hindfoot varus deformity in patients with CP, and the study findings highlight the need to reevaluate traditional surgical indications for correcting hindfoot valgus deformities, and they have been largely based on the severity of the deformity observed on radiographs. The next one is distinct three-dimensional morphologies of arthritic knee anatomy exist. CT-based phenotyping offers outlier detection in total knee arthroplasty by Wu et al. Disclosure, I'm an author on this paper, and this is a very interesting paper in my mind, at least, because it classifies patients into 4 different types. The CT-based phenotyping had a 3D classification of arthritic knee anatomy, and there were types 1 and 3 that represent outliers that's present in 26% of knees undergoing total knee arthroplasty. Prior classifications emphasize native coronal plane anatomy, but this 3D phenotyping of knee allows recognition of outlier cases and provides a foundation for longitudinal evaluation in a morphologically diverse and growing surgical population. Type 1 outlier has increased femoral version and torsion and increased acetabular version, greater amount of slope, like 89 degrees of posterior slope, and extreme TFA deformity, and then it's more common in women and more common in valgus. Type 3, on the other hand, is decreased femoral version and torsion, kind of opposite of type 1, decreased acetabular version, zero or reverse posterior slope, and more common in men and more common in varus deformities. The wild types are type 2 and type 4. So they both have intermediate femoral version and torsion. The relatively lower acetabular version in type 2 versus relatively higher acetabular version in type 4. Similar posterior slopes, 5 to 6 degrees. Type 2 is more common in men, nearly even varus valgus distribution and larger bone size compared to type 4. And type 4 is smaller bone size and more common in women and much more common in varus deformities. And finally, assessment of the mechanical performance of an affordable external fixator is called AFIX, AEFIX, designed for resource-limited settings by Momazed et al. And there's a commentary. Current external fixator assemblies are unaffordable, and they cost upwards of $5,000 of US dollars. And most low-income countries cannot pay for this, and they have to rely on donations because the patient population cannot afford that. There are new affordable external fixator clamps called AFIX, and it's designed for use in these low-income country settings, and they were compared to some of the standard of care clamps, the Hoffman 3. And they looked at mechanical efficacy in axial, torsional, and loading scenarios, mechanical testing at the component level and construct level. And they looked at a uniplanar external fixation of a tibial diaphyseal fracture. And it found that the AFIX clamps were comparable to industry standard Hoffman 3 clamps in terms of mechanical property, both cyclical loading and just torsional stress, suggesting that these AFIX clamps may provide safe external fracture fixation in non-weight bearing, especially in low-income countries. So it's very, very useful because the cost is much more effective. Thanks for joining us again, and we look forward to having you next time.